Hello, everyone, and welcome to our session today, Moving Beyond Technology, Exploring the Clinician Change Virtual Care Toolkit. My name is Haley Warren, and I am a Senior Program Lead here at Healthcare Excellence Canada, and I will be your host today. I'm happy to be joining you from the traditional territory of the Mississaugas of Scugog Island First Nation. I invite you all to introduce yourselves in the chat and reflect upon the land upon which you live, and I see many folks are already doing that. Before we begin, I do want to note that we are very happy to offer this webinar in both official languages. If you would like to listen in French, please select the interpretation button on your bottom Zoom menu and select the French side, and you should be able to hear our interpreter. If at any time you're experiencing technical difficulties, please let us know using the chat, and a member of our team will be happy to assist you today. And as a reminder, this session will be recorded, and the recording will be made available to participants afterwards. So let's move to our next slide. And before we begin, we'll just chat briefly about our objectives for the session today. Today, we are very happy to introduce folks to the Virtual Care Together Design Collaborative, which was a partnership between HEC and Infoway, and as well as the Clinician Change Virtual Care Toolkit, both of which were designed and delivered in that partnership. We will hear from Kevin Sampson, an experienced primary care physician, about using the toolkit in practice, and learn from a design collaborative team about their work and how they used the toolkit to create tools of their own within their virtual care practice. And there will also be ample opportunity to ask questions and learn from one another. And we will close with chatting about and sharing the next steps for Healthcare Excellence Canada in virtual care. And so before we dive into our content, we did want to ask folks a few questions to see where you're calling in from and to see where you're at with virtual care. So we'll bring our polls up now, and we'll give folks a few minutes to answer the questions you see on the screen before we share the results. So asking where folks are calling from, what your role in healthcare is, as well as are you thinking about virtual care, and what types of virtual care you might utilize, and how comfortable you are using those types of virtual care. Okay, so I'm seeing some folks are indicating that they don't see a poll. So let's perhaps try to relaunch that. Just a moment, and we'll get that kind of fixed there to see what's going on with our poll. Just looking to get a sense of where folks are at. We might have to relaunch that. So I'll just call on my tech friends in the background to see if we can perhaps get that relaunched. Can folks see the poll? I would just welcome, all right, I'm seeing it now again. So hoping folks can see that and can start to answer. We should be able to see as answers are popping up. Okay, so I'm not sure what's going on with the poll. Okay, so we should see the poll. I'm not sure. Can someone let me know on our tech end if they can see the poll? Okay, so I'm seeing that we can see the poll, but people are unable to click on it. Oh, I'm seeing some results are coming in now. Apologies about that, folks. So that's one of the things about technology. And as we're chatting about virtual care, when it works well, it's great. And when there's some challenges. So I'm seeing a lot of folks are calling in and joining us today from Manitoba, Ontario, Quebec, as well as BC, Alberta, and Saskatchewan. And it looks like we've got representation from across the country. Many folks are administrators or allied healthcare professionals, as well as consultants, physicians or nurses, or quality improvement leads. Some folks are thinking about virtual care quite a lot and a bit. Good to see that no one has selected that they are not thinking about virtual care at all. And it's looking like most folks are using virtual care through video or through the telephone. Some folks are saying other. Many folks are saying that that they are considering the use. Okay, great to see. And folks are using it a bit. That's wonderful. Okay, so thanks so much for taking the opportunity to answer and getting a bit of a sense of who's all joining us. And so we'll close out the poll now, and we'll keep moving with our slides and with our conversation today. Okay, so we'll skip past these poll question slides. Thank you very much to our tech friends. Okay, thanks very much, folks. So as mentioned, we want to do a bit of an intro to share a bit of information about the Virtual Care Together Design Collaborative and really ground folks in how we created this toolkit that we'll be chatting about today. So we'll go to our next slide. So Healthcare Excellence Canada and Canada Health InfoWay partnered to launch the Virtual Care Together Design Collaborative in October of 2021, and it ran until March 2022. And we focused in on community-based primary care settings. The design collaborative was really meant for HEC and InfoWay to understand what was needed in the space of virtual care through a few different mechanisms. Teams were provided a preliminary clinician change toolkit that contained identified virtual care resources across three main areas: appropriateness of virtual care, quality and safe virtual care interactions, and the use and optimization of virtual care. Over the 6 months we worked together, teams were provided tailored learning supports that included coaching, peer-to-peer networking, and workshops focusing on various elements of virtual care to build teams' capabilities to provide safe and equitable virtual care. And over the course of the design collaborative, HEC and InfoWay were really looking to gather learnings and identify gaps for supports needed in virtual care. And now we're at post-collaborative, where we're really looking to continue to understand what the appropriate strategy is for us to scale use and longer-term rollout of programming in virtual care and to support folks across the country. We have also iterated the toolkit based on feedback, which we will be doing a dive into today and be sharing with folks. And finally, we want to continue to support the delivery of safe and equitable virtual care, improve experiences and outcomes for patients and providers. So we'll go to our next slide. And just a brief look at the folks we were very fortunate to partner with across Canada. As you see here, the 25 teams we worked with really spanned a depth and breadth of geographical settings, clinical services, and areas and populations as well. So seeing virtual care really across the healthcare system within Canada. And we'll go to our next slide. So as mentioned, a major focus of the design collaborative was trialing what we called the preliminary clinician change toolkit. Based on some intensive initial research and discovery work that InfoWay and HEC did together, we created this version of the toolkit that contained resources and tools used to support virtual care across the priority areas identified that I mentioned earlier. So go to our next slide. Folks can see this as a bit of an example of how the resources were shared in the preliminary toolkit, which, as mentioned, was really a repository of resources that we were looking to iterate. And so on our next slide, you can see our plan for how we wanted to iterate and create the toolkit as it exists today. So HEC and InfoWay went through several steps between October and March to understand what was needed to create a valuable resource in this space. And so over the course of the collaborative, teams provided feedback on the toolkit through one-to-one coaching calls and identified suggestions for the next iteration, which were then reviewed by HEC and InfoWay. HEC then identified expert clinician reviewers to create and validate this next and current iteration, one of which you will hear from shortly. We then worked with our reviewers to summarize evidence in the theme areas, compile and create resources to support virtual care evaluation, and led a directed review process to validate this tool. And based on this, we have the clinician change toolkit as it exists currently. So we'll go to our next slide. And this slide is just an example at a high level of the various stakeholders we consulted with, the folks we partnered with, and the resources that were leveraged to develop the toolkit content. Next slide, please. So moving a long way from a repository of resources, the toolkit now contains 4 major sections of content that you see here. Streamlined information from trusted sources, like those on the last slide, from those priority areas of appropriateness, quality and safe virtual care interactions, and the use and optimization of services. Some guidance for virtual care evaluation for folks to really evaluate and consider how they're going to address that in virtual care across 4 main domains: patient experience, provider experience, appropriateness and access, as well as equity strategies in virtual care, and that original repository of virtual care tools and resources for anyone who has time to do a very, very deep dive into all the original resources. So I'm now happy to hand it over to Kevin Sampson, who will introduce himself and share a bit about the toolkit and clinical practice. So over to you, Kevin.
Thanks, Haley. Can you hear and see me okay?
You sound great.
Awesome. So if you could just go to my first slide there. Perfect. So yeah, thanks for inviting me to talk about the toolkit. I'm a family doc and I live and practice in Rockwood, which is a small one intersection town between London and Toronto. So much has been happening with virtual care. It's amazing to see the progress that's being made. It's gotten to the point though, especially as a provider, that it's actually difficult to sort through all the information that's coming at us about using virtual care with our patients. The volume can really be overwhelming. There's a lot of redundancy and it's hard to sort out the opinions from the evidence. This is where the Clinician Change Virtual Care Toolkit really helps. It's a clinically oriented, practical summary of the key points to consider, and it's presented in a concise, mostly point form format. So super practical. I'm going to give a high-level overview of the toolkit and show you how useful it can be from a clinical point of view. So whether you're just thinking about starting to use certain types of virtual care or you're already providing virtual care and could use some helpful tips, the toolkit can really help you provide the best virtual care, best care possible for your patients. We go to the next page, please. There we go. So the first section of the toolkit, as Haley was saying, is on appropriateness. When is it appropriate to use virtual care? And when is it probably best to see a patient in person? This is a big question in healthcare right now. It's challenging because there's so much to consider. The toolkit breaks this down nicely. Clinical considerations, of course, are an important factor. Is the patient's pertinent medical information available? What's the quality of the current therapeutic relationship? Would it translate well to a virtual visit? Are there symptoms or concerns that would require an in-person assessment? So these are just a few of the clinical considerations listed in the toolkit. It also gives lots of good examples of situations that would typically be amenable to virtual care and those that wouldn't. Patient and caregiver considerations are also nicely outlined in the toolkit. There's a helpful list of questions about this. Do they have access to the technology? What's their comfort level with it? Do they have access to a safe and private space for virtual care? Do they need support services to use the technology? You'll find a helpful set of questions like this in the toolkit. And it's good to see that it makes it clear that patient and caregiver preferences should be prioritized whenever possible. And to help choose the best modality, there's a comprehensive table showing the benefits, uses, and limitations of each: phone, video, secure messaging, and remote monitoring. Next page, please. Choosing the virtual care tools that best suit the situation and making the best use of them is also well covered in the toolkit. How do you choose the technology? Does it meet the required specs? Does it integrate with your EMR or other information systems? How well will it fit in with your workflows? Is it easy for providers, staff, and patients to use? How well does it support standards of care and best practice guidelines? Again, just a few of the useful questions listed in the toolkit. With regard to privacy, the toolkit outlines a number of steps that can be taken to help ensure that privacy is protected. Getting proper informed consent, authenticating the patient's identity, confirming that the patient is in a private location and being in a private location yourself, making sure that you're using the virtual care platforms properly so that they provide security functionality that they're designed for. These are just some of the important steps listed. Workflow. Workflow is often either overlooked or just an afterthought, but it can really be the determining factor when it comes to whether virtual care works well or not. The toolkit has lots of great points to help with this. Engage your team. Find out about their needs and provide them with good training and support. Establish good practices so that it's clear about who does what. Optimize scheduling to accommodate virtual care. and look at strategies for onboarding patients that would best fit your practice. The toolkit lists lots of helpful workflow tips like these, which will make a big difference for providers, staff, and patients. Next page, please. Improving the quality of virtual care interactions leads to better patient experiences and outcomes. The toolkit includes a set of guideline recommendations to help prepare for and conduct virtual visit. It also includes some excellent patient handouts on this. There's a much needed section on virtual physical exams. This is all relatively new. I certainly didn't learn about this in medical school. It's surprising how much can be done through physician-guided patient self-examination. The toolkit includes some excellent how-to videos and article references to help clinicians understand more about this. There's lots of important tips on safe prescribing in virtual care, having access to the patient's medication information, questions and discussion points about taking the medication, and the use of electronic prescribing platforms to help ensure that the right meds are prescribed to the right patients in a secure and timely manner. Health equity. Equity is a very important consideration with virtual care, as I'm sure you are all aware. We need to recognize the potential causes of digital health inequities and have strategies in place to mitigate them. I'm going to use the next few slides to expand on this. Next slide, please. The toolkit shows that we need to recognize that all communities have their own unique needs and sensitivities. Next. The toolkit also outlines barriers to equitable access that may exist with virtual care. Disabilities, distrust in healthcare providers, systems, or technology, lack of access to technology or data services, and lack of comfort with tech and lack of tech literacy. Next page. The toolkit breaks down all these factors into individual, technological, health system, and social structural levels. It spells out the issues and provides mitigation strategies in a table format that's clear and concise. It's certainly worth taking a look at. Next slide. Having implemented virtual care, we need to be able to evaluate it. How well is it working? How can it be improved? It hasn't been clear, though, how this is best measured. HEC and Infoway convened a virtual care evaluation committee to help with this. The result is the Virtual Care Evaluation Guide, which is part of the Clinician Guide Toolkit. The evaluation guide expands on each of these factors, including a range of perspectives to ensure that the results represent the people being served, equity dimensions that should be included across the evaluation so that the data can be stratified according to equity indicators. Assessing virtual care modalities, so phone, video, secure messaging, etc. I've seen a lot of evaluations in which virtual care of all types or modes is lumped into one big bucket. The guide reviews how being able to differentiate the results by modality can provide more meaningful insights. There are also some key points about data quality, validity, availability, and collection, as well as references about ethics, privacy, and security. It also provides a good mix of evaluation measures and survey questions. They're mostly focused on patient and caregiver experience, provider experience, appropriateness, and access. Next slide. The last section includes a short summary of each of the virtual care tools and resources that are referenced in the toolkit. Key points, or pearls, were collected from each of these references to inform the toolkit. It's been so helpful to use the toolkit to cover the bases of virtual care and then to link to these resources for a deeper dive into areas of particular interest. It's helped me to better integrate virtual care into my practice, and I'm more comfortable and confident with the virtual care that I'm providing. I've had lots of positive feedback from my patients, and they're appreciating the virtual care as much as I have. So thanks to HEC and InfoWay and everyone who contributed to this. I hope you'll be inspired to explore the toolkit and discover how effectively you can provide virtual care for your patients. Thanks.
Thank you so much, Kevin, for providing an overview of the toolkit, and huge thanks to you for helping us as HEC and InfoWay get it to where it is today. We have had a few questions in the chat, but just as a reminder to folks, we will keep note of those and we will save them for our question and answer period at the end. And as another reminder, we will be sharing all materials, including the slides and links to the toolkit with participants when the recording for the webinar is made available as well. We're now very happy to hand it over to one of the design collaborative teams from Access Alliance Midwest, Kasia and Phaeton, who will share about their work, introduce themselves, and let us know how they use the toolkit to develop their own tools and improve their virtual care practice. So over to the two of you.
Hello, thank you very much, Haley. I will share with you if we go to our slides, and then I will pass it on to Kasia as we move forward. So if we can go to our team slides, please. So that's just the core team here. The next slide. Just wanted to let you know that our core team was made up of primary care providers from the different primary care models, a quality improvement advisor, and we collaborated with patients, booking staff, doctors, and nurse practitioners from family healthcare organizations. So the next slide. And what we were tasked with, the team identified that they needed a simple decision tool to be used by the front desk to help them make a decision on appropriately booking virtual care appointments. And we wanted to make that tool as practical as possible, as easy as possible for the frontline staff. So we really focus on practicality. And when I talk about booking virtual care appointments, I am referring to phone and video. Those are the two types of virtual care. So if we look at the tool here, as you can see it, you might not be able to read it, but I know the slides will be shared. So you'll be able to read it. But the tool was developed actually based on a process map that was then simplified to a decision tool for booking virtual care. And it was to be used outside the pandemic environment, and when there is a specific pandemic protocols, that the protocol should be followed. And we aim to create a general tool that could be used in primary care setting. And a tool that could not be only specific for certain condition, we wanted it to be for any conditions. So it was developed with primary care setting in mind. However, because it's so general, we identified that it could also be used in specialists' office as well, based on their setting. And again, it was developed in a way that it could easily be adapted based on each office context. Now, we just want to let you know the assumptions we made while we were creating this decision tool was that if the patient says, I want an in-office visit, that patient would be giving an in-person visit so that they don't come back for the same issue again, because we don't want to increase the number of appointments for that patient. And if you look at the bottom of the tool, you see these blue boxes. And those blue boxes we thought were really important notes that we wanted to make sure that who was using the tools would look at it. For example, the first box dealt with urgent care appointments, that this tool, decision tool, does not deal with urgent care, and that each practice has to follow their own protocol for urgent appointments. The second box dealt with the appropriate conditions for booking virtual care. So again, based on their context and their environment and their patient population, they would decide who was and who was not appropriate for virtual care. And we will speak to that, Kasia will speak to that shortly, about how we decided which virtual care appointment. The third box provides or addresses how to deal with patients who are outside of your jurisdiction. So for example, in Ontario, if a patient calls their provider and they're outside of Ontario, care is deemed not to, the doctor can't provide care when they're outside of Ontario. So you really need to look at your provincial rules and regulations about that. And so now I am going to pass it on to Kasia to talk about the one pager that we created that works along together with Decision Tool. Kasia, and the next slide, please.
Yes, thank you, Phaeton. And hello, everyone. My name is Kasia Philiber, and I was supporting this project for Access Alliance with Phaeton. As Phaeton mentioned, I will speak to this one pager that supports the Decision Tool for booking virtual care appointments outside of pandemic environment, because we realized that during a pandemic, specific guidelines apply and this tool would not work. So why did we create this tool? Physicians in our group identified that it was challenging to use the virtual care together toolkit. The whole document is as a reference for making decisions. The information in the toolkit is amazing and rich, but it was overwhelming for an individual practitioner to use the toolkit on a daily basis. So we decided to summarize the relevant information all in one page. We selected two tools from the toolkit, the CMA's Playbook and U of T Center for Effective Practice, to create a draft one-pager that summarizes the advice from those tools on when it was appropriate and not appropriate to book virtual care appointments. And the goal was to have a one-page format, as it makes it easy to print and disseminate the resource and to have on hand by booking staff. So as you can see, barely, because it's probably very tiny right now, there is a general information about booking virtual care appointments. And then below, there's more specific information about phone and video appointments. And as a reminder, our project defined virtual care only as phone or video. A draft one-page document that you see was reviewed by the physicians in our group and also tested in their clinics by in the participating CHCs. It was used by the booking staff as well, and they provided feedback. It was very well received, and only one addition was made related to the patient's presence in Ontario to receive virtual care. All the physicians felt that this tool will be very helpful to standardize the booking process. In addition, they felt it would be very useful to educate the patients about virtual care appointments. One of them mentioned that he wanted to blast it on his forum to all the patients who had access to electronic tools to be able to read about virtual care. As an educational tool for patients, this tool would need to be translated for many clinical practices, because we do see a lot of people whose first language is not English. We did not have a chance to collect data on the impact of the decision tool in this one pager. We did do some work on the baseline data, which grew momentarily. And if there are questions, I'm happy to answer them. So back to you, Phaeton.
Thank you, Kasia. So next slide, please. So we wanted to make sure we developed project measures, and we developed 6 project measures. So 1 outcome, 3 process, and 2 balancing measure. And an outcome measure is a measure that allows us to see if we are achieving our goal. And they're also known as lagging measures because they're like a big boulder that you're trying to move. And process measures are those measures that allows us to see if we're doing the activities we need to do in order to achieve our goal. And they're called the leading measures because they move much quicker than lag measures or outcome measures. And the third type of measure is balancing measure. And these measures will allow us to see if we negatively affected something else in the system. And we wanted to make sure we would capture those measures as well. And as Kevin says, data quality is really, really important. And so what we did is we developed what we're sharing with you is a mini measurement plan to ensure consistency of high quality data collection and for each of those measures. So in the measurement plan, we created an operational definition, which an operational definition means that we all understand everything the same way. For example, if we all said our meeting is at 1 and can we meet early, but somebody comes at 5 to 1 and somebody comes 10 to 1, somebody comes 3 to 1, we're all early, but we all have a different definition of what early means. An operational definition makes sure that we're all on the same page. So for example, for the outcome measure, we had, as you could see, the outcome measure was the number and percent of appropriately booked appointment. But what does appropriately mean? Well, appropriate means virtual care appointments are those that are booked according to the list of conditions created by your practice, and that goes back to the one page. In the balance and the process measures, I'm going to really just focus on the bounce back measure. That one I really thought was really important to touch on here in the webinar. And we define the bounce back measure are those patients who come back in person for the same issues within 3 weeks following the appointment, and it was not a follow-up appointment or that the condition then worsened, which means that the virtual care appointment wasn't appropriately booked. So we wanted to make sure that that measure was in there. And we built on this bounce back measure after speaking with Shauna Tom, the ED from Crowfoot Village Family Practice, after one of these meetings, one of these webinars that we attended. And then the balancing measure is, what could negatively be affected in the system? And one of them was we identified that referrals to imaging and testing increased. So while virtual care was great in the sense that we could, see more patients virtually, but if we're stressing the system by having people go for more imaging or testing, then we're just moving the problem. And so therefore, was that really happening? So along in this mini project measurement plan, as you can see, the first column is the measure, the second column is the operational definition and the description. The third column we wanted to do was really talk about how are you going to calculate that? Because again, if we're going to calculate it differently, we're not going to have high quality data. It's not representing what we need to do. And therefore, we wouldn't even be able to compare across sites, or if anybody else wants to use these measures, if we can, and they do, we want to make sure we're all collecting it the same way. So we did decide to calculate both number and percentage of each measure, and calculating the percentages will allow us to compare across. So let's take the example of bounce back measure. How did we do that? So the way that we calculated bounce back measure was we took the number of patients who came in for in-person for the same issue within 3 weeks. So anybody who came back for the same issue within 3 weeks, but not those who came back for a follow-up or a worsening condition. And we divided that by the total number of virtual care appointments for that same time period study. And we didn't have enough time or space in this slide deck to share with you a real example, which we did in our mini project measure, which I'm sure if anybody's interested, they can contact us and we'd be happy to share it with them. And we tested these measures for baseline data collection just to get a sense of how booking virtual care worked in a practicing clinic. However, we have not had a chance to collect data on the use of the new virtual care booking process or tool that we've created. So I think that covers everything about the measures. And as you can see here, we have the one and then the three. On the first slide, you have 2 of the process measure. And on the next slide, you have a third process measure, and then the last 2 are of the balancing measures. And that's it. And I'm going to hand it back over to Haley.
Thank you so much, Peyton and Kasia, for sharing and for your presentation. We have had some questions in the chat already, so we'll get all of our presenters back on video and ready to have a fairly hopefully lengthy question and answer period. So we'll open it up. Folks are free to put questions in the chat or to request to raise their hand to unmute if they'd like to come on video and say hello virtually in that way. But we'll get started with our first question that we had from Rebecca, which was during our toolkit portion of the presentation. Which methodological approaches did you take to determine the domains, appropriateness, etc., and subdomains of your toolkit? So I'm happy to answer that first from an HEC and InfoWay perspective, Kevin, and then perhaps hand it over to you from a clinical perspective. So what was mentioned quite briefly at the start of our conversation was that in order to identify the resources that went into the toolkit, there was quite an intensive research and discovery phase to not only identify those resources, but also for HEC and InfoWay to understand what clinicians and support staff and patients identified as being the most important topic areas to them in the space of virtual care. So there was quite extensive scanning done, focus groups and interviews, environmental scanning. There was some social media outreach that identified those topic areas of appropriateness, quality and safe virtual care interactions, and the use and optimization of being the top priority. And it was from there that that initial research and discovery dug down to get the full repository of tools that existed. Originally, 169 tools from across Canada were identified. That was then through that iterative process brought down to 14. And those were the 14 tools that teams worked with in the repository of tools to ultimately create the toolkit as we see now, as Kevin described it. So that's how we got those domains. But Kevin, I'm happy to hand it over to you for just some clinician expertise on how we kind of created some of that streamlined information and whatnot.
Yeah, definitely. So keep in mind that this is a toolkit, the Clinician Change Virtual Care Toolkit. This is not a publication. There's enough of that. There's lots of that, and that's where it gets overwhelming. So the one of the goals was to be able to take the real pearls, like I was saying. What are the key points that we can present to clinicians, and not just clinicians really, but anyone who's involved in the provision of virtual care. But how can we really condense this into something that's easily manageable from a clinical point of view? So essentially, as Haley said, a lot of work has been done, and we basically looked at what was going to be clinically most relevant so that we could put this in a digestible format that would be practical on the front lines. And that's the beauty of this. That's basically what we've created. And then as such, people can then come into the toolkit, as you heard from Kasia and Fet, and just recently is they can come in and take what's going to work for them and create their own, even more condensed, here's what's relevant to our particular situation. So that's the flow that we're looking for. So it's really good to see that it works that way.
Thanks, Kevin. Appreciate you providing that additional clinical context about how we got to where we did with the toolkit. And one of the great things about having you folks at Access Alliance present, as Kevin said, you really show how you can use the toolkit and take it to make it relevant for your considerations. So our next question is from Tamara Stevens of Doctors of BC, and I believe it is for you folks at Access Alliance. Just wondering if you offer tripartite virtual visits, physicians, specialists, and patients.
All right, go ahead, Kasia. Did you want to answer that?
Sorry, what was the question? I started reading the answers. I apologize. I just lost track.
Not a problem at all. So just a question from Tamara Stevens of Doctors of BC asking if you folks offer tripartite virtual visits, physicians, specialists, and patients. And I see Kevin has his hand up. So after you folks answer, we'll go over to Kevin.
Yes, I think it would be better answered by Kevin. I haven't worked with the physicians in the clinic to be able to say that, but I know that there is work done in Ontario to be able to coordinate visits and do visits with specialists, or sometimes visits with home care, or like just shared visits.
Thanks, Kasia. Kevin, something you
Yes.
wanted to add?
Yeah, absolutely. So and to expand on the question even, so this is where virtual care can really provide more than in-person care in certain ways. So we have had in my office we've had meetings where I'm actually in the room with the patient, and virtually we have a team. In this case, it was a psychiatrist and a pharmacist, a social worker, myself and the patient. And in that case, the patient and I were actually in person, and so that was a real hybrid. We've, especially during the pandemic, we had meetings, for example, with our diabetes team, where we'd have a diabetes nurse, a dietitian, myself, and the patient in a virtual meeting. And that really wouldn't and wasn't happening with in-person visits before the pandemic. And it's even continuing now that we're a lot more in person. We're still doing that because that works. And back to what we were talking about how important health equity is, virtual care really gives us some opportunities there. So we can have a visit where I'm doing a video visit with the patient and they have a caregiver or a translator or just someone else that can help that they've invited to join the visit. So it just opens up a whole realm of how we can move forward with healthcare, and it's been great to see. So thanks for the question.
Thanks all. I think I will skip ahead because there was a question that came in at the end that's related to that last point you made, Kevin, but no worries, anyone else. I will not forget the other questions that are above that, just from Diane Edland in BC. Related to Tamara's question, I would be interested to learn if you looked at providing advice in the toolkit regarding tripartite virtual visits with patients and family caregivers in the same or other locations and physicians, clinicians. So happy for you to go ahead, Kevin, and then I can just provide a little bit of context from the HEC InfoWay perspective on that as well.
Yes, excellent. So the toolkit does provide pointers about this. So things to be thinking about, and the structure of it is if you find a few things like this that you're really more interested in, the toolkit will provide you with links to more detailed information. So depending on what level you want to look into this, it's there for you.
Thanks so much, Kevin. And yeah, echoing that, the toolkit does provide those considerations. And as well, we did have teams within the Virtual Care Together Design Collaborative that was something they were specifically working on, ensuring that their virtual care allowed for that integration of patient family care partners and in that kind of shared decision-making space between patients and between providers as well. So thanks for that question. And thanks for that, Kevin. So we have another question, moving back to some of your measures, Feitan and Kasia. Was there a baseline % of bounce back appointments for in-person?
Can you hear me?
Yep.
Perfect. No, we didn't. And that's why we actually created this project measure so that we can get some baseline. So we used it to get baseline to figure out where we were, because we figured it's going to take time. For example, the bounce back, it was going to take time before we can actually wait for 3 whole weeks to see. So we mainly used it for a baseline.
Oh, can I just kind of elaborate that? So you're saying that your baseline is going to be based on a virtual baseline or like pre-virtual care? Because like to what Kevin had mentioned earlier is that, you know, and I've done some environmental scanning, people think that virtual care or it's going to be siloed, but what Kevin said, and I completely agree with, is that it's not. It's part of a healthcare continuum where patients going to bounce back and forth between in-person and virtual. It's going to be this ebb and flow where they go back and forth. But if and I agree with whatever everything's been said, it's really hard to measure. Is virtual care fantastic? Like how do you evaluate it? But we need to compare it to something, and what people want to compare it to is in person. So with that bounce back rate, you know, what is going to be a good or bad percentage? Obviously we want it to be 0, but like in person, we would expect it to be 0 because you don't want to be treating patients and then they come back. It's the exact same thing. It hasn't gotten better, gotten worse, or it's not a follow-up. It's just they're coming back 3 weeks later because they still have back pain. Like the medication doesn't work. And I'm just using that as an example. So, you know, I'm having difficulties finding like, hey, how do we compare it to an in-person care? Is it going to be that bounce back rate, which, you know, fine, but what is acceptable? I don't know. And all the environmental stuff that I've read, they're kind of skirting around the issue. Like, and I've talked to a couple of groups, they don't want to get into that area of metrics because they know how muddy it can get, and there's no accepted rate of bounce backs, of no show, because I could even say, you know, how many times were there no shows due to family emergencies, whatever it might be, and go, okay, how many times did virtual care drop out? Is that same or relatively within the ballpark of your virtual care? So I think that's what I was getting, is like, is there a bounce back percentage that you are comparing to for totally in person, not even thinking about virtual, because there has to be that comparator.
Thank you so much for asking. What a great question. So again, project measures, when we figure out what our outcome measure is, what we were trying to achieve, the whole tool was based on for frontline staff to book the most appropriate appointment. So again, if the patient wanted to come in person visit, they definitely came in. But if not, then the frontline staff had to decide whether to book virtual or not. And that's where the one pager came in. So when we look at our outcome measure, it is the definition for appropriate virtual care appointments are those that are booked according to the list of conditions created by each practice. So that's that one pager that Kasia has spoke about. So the bounce back is measuring the outcome measure, so it's directly related.
Okay.
And what we're measuring is, are the frontline staff booking appropriately, or is that person coming? Now, if you are looking at bounce back from how do we compare it with in person, you're looking at a different outcome or something else. This is basically geared specifically to this tool for the frontline staff. Are they booking those appointments appropriately based on the practice's context and that one pager that they've decided? So we got to make sure that the project measures are going to be dealing specifically with that which you want to address.
I
Does
understand.
that help?
Yeah, that totally understand. So then, you know, based on that, you can either change the definition of what you deem to be appropriate, or there might need to be more education for your frontline staff to say, look, people are calling in with this, and we're actually not, they should be coming in person when we're giving them more virtual appointments, or vice versa. So, okay, I agree with that. But then I think my mind just got switched to, can we use what you did and scale it up a bit further and get a broader picture of virtual care as a whole? And maybe this leads to another question I had, and I apologize. I'm like,
No, don't apologize. That's excellent. That's terrific.
I'm bogarting the whole conversation, is just because it's an area that our program's looking into, is how do we evaluate virtual care as a whole, and can we scale up what HEC has done here with this toolkit and make it more of a system level approach to evaluating virtual care? So as a province, can they evaluate virtual care, but then each specialty can take those questions and scale it down to their locus of control?
So I want to, first of all, thank you for bringing clarity, because you wanted to ask a question, so you brought clarity to your question and what you wanted. And the second thing is, I love the fact that you're asking a question, and it all starts with a question that you're trying to answer. When you figure out what exactly you want to achieve, which is how do we look at virtual care overall, that's a different question you're asking. And that's how now you have to use that question and come up with the measures that will help you measure that specific question from, I mean, I don't have the time to go into it here, but there is actually a method of how to do that.
Thanks very much, both. Great discussion, and no one should ever apologize for asking questions. That's what the learning exchanges are for. I see Kasia and Kevin, your hands are up, and I am cognizant our time is ticking down and we've got some other questions. So before I throw it over to you two, I will just flag, if we do run out of time for questions, we can share anything that has been unanswered with the presenters, and we'll make a commitment to share that back with you folks when we share all of the materials from the session as well. So over to you, Kasia.
Yes, thank you. So I love the evaluation questions. It's really interesting and important. So to add to what Faten was saying, the baseline was only to see whether there's an improvement after using the tool in the one pager for booking staff. So having a baseline to see whether there's an improvement. And as you noted, we really don't know what's actually good bounce back or how it compares to primary care. And that's a really important question to ask and to measure.
Yes.
Thank you.
Thank you. Kevin, over to you, and then we'll go to our next question.
Thanks. I'll try to be quick, but I'm so excited about this stuff. I think it's so important to look at, to what extent are appointments being made virtual that shouldn't have been, that therefore required an appointment later in the office. Very valid. In addition to that, though, I don't want to lose sight of the fact that we're not really talking about it's either virtual or in person. It's a continuum like everything else in our practice. And I've certainly seen lots of great examples of what I would call hybrid appointments, where, and they are appropriate, where we have a that we say, and let's do a follow-up in person in the office. And there's lots of good reasons for doing that. Sometimes people won't take the time or can't take the time to come to the office, and they don't realize how important their situation is. We can help them understand that, and that brings them to the office. Sometimes we have a patient who has a virtual appointment and we say, you know what, get this test done and that test and check your blood pressure 4 times. And this is write down your diet, and I'll see you in the office in a week and a half. And the appointments work really well together. So I'd like to also acknowledge that in addition to bounce back, maybe we should be thinking about hybrid. And if you want to know whether an appointment that was virtual was appropriate or not, I can't think of a more accurate way than to just have a little flag in the chart or at the end, as part of the visit, where the clinician and the patient both get to say, was this appropriate or not? Because there's so much variability in what's appropriate or not. I think that would be a truer measure.
So thanks for adding that, Kevin, because we didn't go into it in detail here because we didn't have the time, but we did have a piece for the providers to also say, was it appropriately booked or not? But we just didn't have the time to go into it here.
Perfect.
Thanks, both. And that ties in with some of our other questions we've had about measuring and evaluating appropriateness as well. We do have another question from Alex Singer. How were you able to differentiate a follow-up from a repeat visit for the same issue?
And that's where, exactly, speaking back to Kevin's point, now what's the physician who says this was appropriate or not appropriate appointment, and that's how it was the physician and the patient who decided whether it was appropriate or not.
Thank you. And I do think that answers kind of one of our other questions from Zara. Are there any criteria that evaluated appropriateness? And I know something you folks were looking at. I'm not sure, Kevin, if you wanted to speak very briefly to what's in the toolkit itself, and then I can hand it back to you, Kasia and Faten, before we have time for a few more questions, and then we'll have to close out. But such a great discussion.
Yeah, I think this whole session is really about the toolkit and how to use it, not about the answers that are in there. And so to answer that question, it's yes, the toolkit covers that very clearly. And I think you'll find that what you're looking for is clearly laid out in the toolkit. So take a look at it and you'll see.
Our definition of appropriate was what is appropriate according to the physician that is using the tool and the patient. So there really isn't a universal definition of appropriate.
Yeah, because as we said, if we book somebody, a patient wanted to come in person and we didn't book them for an in-person, they will come back, and we know that for a fact from research. So it's what is appropriate for that patient. So we wanted to make sure we heard the voice of the patient as well in our tool, the decision tool, and the physician and their practice and their context. That's why we came up with that list based on their patients and their patient population context. Yeah.
And there are some great examples in the toolkit that really make the point to give people a feel for what's appropriate and give them sort of a bigger picture. And I think it's helpful to go through those examples.
Thanks, both. I'm cognizant we only have about 5 minutes left, so I'm going to ask one more question that was shared. And again, any questions that are in here that we have missed, we can absolutely commit to sharing those back with our wonderful presenters today and ensuring that that material is fully translated and shared with everyone when we share the workshop materials from today. So we just had another question from Mireille asking, I am curious if there have been any discussions and considerations regarding interdisciplinary care using virtual care, where you could potentially have multiple health disciplines collaborate with the patient to support their care needs. This was a hot topic for our virtual care together design teams. Lots of folks who are looking at this and lots of folks who are working on that in a few different ways, but I'll hand it over to you, Kevin, and then Feitan and Keisha before we close out for the day.
Yeah, I mean, to follow up on some of the examples as I was giving before, that really factored into a lot of discussions when we were in design mode for the toolkit. And I think that there's a lot we're learning as we go, but there's already a lot of lessons learned. There's a lot of evidence out there, a lot of guideline specifications. And I think that it's really helpful to see and be aware of all the options when it comes to how it can work with having combinations of people engaged in the virtual visit.
Thanks, Kevin. Anything you, Commissioner Feitan, would want to add?
Well, I just would want to second Kevin that virtual care provides an amazing opportunity to really do those joint and shared appointments with a variety of providers, especially when those providers are not available where the patient resides.
Yeah,
psychiatry, all kinds of, Sorry.
I agree with both of them. And we actually had the discussion, is this appointment really, could it be done by a nurse practitioner or a dietitian? Who's the most appropriate? We did have that conversation as well in our group. So definitely.
And I just have to put in a plug for secure messaging, because I noticed at the beginning with the poll, I think one person responded that they're using secure messaging. That can be, and in my experience certainly is, a critical, important part of how we can improve access to care for our patients. The problem that it gets around is synchronicity. So with virtual care, if we're talking about video or phone, we have to have schedules aligned. With secure messaging, we don't. And there's a lot of people out there that will be able to receive care that they wouldn't otherwise be able to receive. And frankly, physicians providing, or clinicians providing the care using asynchronous virtual care in the form of secure messaging. I've been doing that since well before the pandemic. And also, I mean, people are used to texting back and forth and messaging back and forth. It's the way things are evolving, and it's not to replace other things, but it certainly can enhance our virtual care, what we're able to provide in virtual care. So I'd strongly encourage people to look through the toolkit and look at some of the advantages of using secure messaging and how you could perhaps bring that into your practices.
Yes, Kevin, I just want to add that one of our providers actually said they use WhatsApp because it's secure, and he uses it within his team and with patients. So again, and they're comfortable using it. And
to me, and you'll see this in the toolkit also, that a big part of the success of whether this, especially from a provider point of view, is integration. And WhatsApp is great. It's outside of the charts, and you have to go out to use it. So there's also secure messaging that's available, that's integrated with the EMR, so that we're in the patient's chart and we can interact with them securely that way. Kind of like email, but it's secure enough that it meets all the standards that are required.
Thanks so much, folks. And I am sorry, I'm cognizant we have 2 minutes left, and there's many reflections in the chat and kind comments about your presentation in the toolkit, as well as the links to the toolkit in both English and French can be found on either HEC or InfoA's website. But perhaps just to close out, we will bring our slides back up. And again, I will remind folks that anything that was not answered, we will commit to making getting this back to folks. So we'll go to our next slide, and just with our last few minutes, just highlight kind of, one of the things of the design collaborative is we were also really looking to understand what future priority areas and focus areas for virtual care work would be. And we identified some of these that you see on the screen through the collaborative. So welcome folks' reflections on those in the chat. Is there anything missing or anything that really resonates with you? And And just want to take a moment to say thank you so much for your thoughtful questions and your discussion today. I always wish we had more time. And so if folks, actually, we're going to launch some polls. Your feedback is very important to us. So if we could, if you take a few minutes as you're closing out, just to let us know how you felt about the webinar today, that would be very valuable. And again, recording will be made available. And thank you all so much. We look forward to continuing to connect with you on this virtual care journey. Thank you, everyone. Have a wonderful day.
Thanks, folks.
Thanks.